and it is less common in females, 1 in 400,000 and 1 in 100,000 females. So the chances of having identity disorders is more common in males than in women. When we talk about transgender, it's the state of one's gender identity or gender expression not matching to one's assigned sex. That is transgender. And there are various ifs and buts in it. So this is not a complete definition covering all the aspects. This is a basic definition that I feel that I am a female, although I anatomically I am a male. So that is again the problem. Gender identity disorders not otherwise specified in DSM involve cross-dressing without identity problems or preoccupations with castration without desire for sex characteristics of other sex. It's unfortunately, again, as I mentioned, more common in men and less common in female. And the role of sex hormones is one of the things that plays a role. This is what was the hypothesis. And children in one study adopt gender identity imposed by parents, regardless of their genetic sex. So if the parents say that you are a girl, even though if he is a boy, he will start behaving like a girl, and then he will progress through it. This is one of the hypotheses. Again, the data related to it is not as concrete as it should be. And some believe that gender identity is malleable. So that is the basic concept. We are not sure what we are dealing with. Behavioral perspective, parental encouragement, feminine behavior, lack of male playmates, or peer or racism is unfortunately all those things play a vital role. So if there is one boy of 5 sisters, then of course he is living with 5 sisters and he sees them dressing up, getting makeup, how they wants to again get out and socialize. So usually these males adopt most of those tendencies, but this never again is concrete that this will lead to gender identity disorder, but this is one of the things. Psychodynamic perspective is unresolved Oedipal complexes or unsuccessful separation individualization. Again, it's just a theory. It's not proven with the facts and it's not proven with the data, so I don't know. Heterosexuality is a romantic or a sexual attraction or behavior between persons of opposite sex. It is called equal love. The campaign to, again, so one gender is attracted towards another gender, and that is heterosexual. This is common. Homosexual, when one gender is attracted towards the same gender, it is homosexuality. It includes the gay and it includes the lesbians. And there are multiple examples in day-to-day life in Pakistan as well as in US. Mostly these things are related to again, celebrities, which are more common because they are highlighted more in social media and other medias. So it's more attracted. Bisexuality means that I am attracted to the male and I am attracting to the female as well. And we believe that so what? So we can be attracted to both sexes. So bisexual is a romantic or sexual attraction or behavior towards both males and females. It is also called pansexuality. So pansexuality, bisexuality, homosexuality, and there is one more term, asexuality. Asexuality means I'm not interested in men and I'm not interested in women as well. So asexuality or no sexuality is the lack of sexual attraction towards any one of them. I'm a male. If I'm a heterosexual, I should be attracted to females. If I'm a male, I'm attracted towards a male, then sexually attraction. Then I am again homosexual. But if I'm attracted towards both, yes, that is also a possibility. And the fourth possibility that I'm not attracted to any one of them. So I'm not interested in having sexual relationship with either women or men. Usually we don't talk about this, but this is a very common presentation in psychiatry if you start talking about it. And we usually don't talk about these. Treatment of gender identity disorders. So once we are sure that this person is having a gender identity disorder, now there are biological consequences of it, there are social consequences of it, there are psychological consequences of it. And I was talking to somebody that there is a set type of a treatment paradigm for all kinds of these kinds of disorders. And usually I don't know it's right or wrong, but it's complicated. So if somebody comes to me, like I was seeing a girl in Services Hospital long time back, probably 25, 30 years ago. And she was very much interested in getting her sex changed. She wanted to be a male and she wanted to go for a surgery. Uh, And same when I started my FCPS training in with Professor Mubashir, we saw a couple, two girls, and one of the girls was there in the department to get her sex changed as a male because she wanted to get married to that girl. So we had a long discussion about it, and that was the first time when I felt that psychiatry is so important in clinical practice, considering these disorders as well. And we saw the girl for a long period of time. And at that time, I read what is the basic treatment guideline. So the ideal treatment guideline says that a person who comes to you as a psychiatrist, comes to me for the treatment of their gender identity, I have to first assess them for psychiatric mobility. If I'll be able to rule out the psychiatric mobility, that the person is not suffering from any delusions, obsessions, phobias, or anything like that, and no primary psychiatric mobility is seen, except for the fact that they want to get their sex changed, which usually takes about 3 to 6 months, then they are actually engaged with the psychologist for a period of 2 years. And in those 2 years, people go through intensive counseling, psychological help, and various other paradigms in psychology are implemented on them. Like the basic principle, crux of the matter is that we should not make a mistake. So once the surgical thing is done, it won't be reversible. It will be irreversible. So before we go for some invasive kind of surgical intervention, we want to make sure that the person would be able to cope with the change. So usually in those 2 years, the small steps are the person is asked to dress like a man or a female for a few months, interact with the people like that. Dressing is just the first step, and then getting more with it. So having socialization with men, having socialization with the same sex which they believe they should be in, acceptance of the family, acceptance of the peers, acceptance of this, again, society in general, when they are dressed like a man is dressed like a female, moving through that. And if all those things are successful in a year's time, then they are given some, after this exposure, they are given some hormone therapy so that whatever the sex they are, they should adopt the characteristics of the opposite sex. Like females are given the male hormones, so that their breast goes away, their voice is more hoarse, they should not have any menstrual cycle or blah, blah, blah. And then, even then, if that is successful and everything is completed, they are recommended for the surgery. Now, this is a very complicated and a very brutal strategy because it takes at least 2.5 to 3 years time to have all these things. Ideally speaking, if you follow all the steps, so 3 years, that person keeps on suffering. He has to face the parents, the peers, the colleagues, the psychiatrists, the psychologists, the other mental health professionals. The person endocrinologist will be giving the hormone therapy and then the surgery. And in my lifetime, I have seen only 2 people being successful enough to pass all those barriers and reach up to the extent of a surgical intervention. And those 2 people were also, as far as I recall, were unfortunately having multiple other issues as well. So they were not successful, but they were partially successful. And this is what most of the literature is suggestive as well, that most of the time, the surgical intervention, or before the surgeons are ready to do the surgery and they intervene, they can cut out the things and they can remove the things, and they do the plastic surgeries as well, and vaginoplasty and all that stuff. So it's a challenging job for them, so they do it. But are they successful afterwards? So the data related to it is also limited. And whatever data I have studied, 2 out of 100, which I have come across as well, are successful people. So 10%, 2 to 10% of the people are successful in their lives in following these procedures. This is unfortunately the irony. Now there comes another paradigm where we call those things paraphilias, intense sexual urges regarding non-human objects, suffering, and non-consenting others, lasting at least 6 months. DSM-4 requires acting on urges or being distressed by fantasies. So this is paraphilias. So the one thing which comes in again, paraphilias, I will just talk about that too. This is the reason why I have included paraphilias into it is, so it is unfortunate that there is intense sexual urges regarding non-human objects, suffering, non-consenting others like rape, and lasting at least 6 months. So this was DSM-4. DSM-5 changed few of the things. So I'm quoting the background, not the current situations, like ICD-11 is missing with some of these terms. Paraphilias involving non-human objects. One is called fetishism. Fetishism is sexual attraction to inanimate objects like panties, shoes, rarely among women, mostly common in men. So they have sexual gratification with inanimate objects, mostly related to opposite sex, and the sexual gratification comes out of it rather than with the actual sexual act. So this is fetishism is again common, about 1 to 4%, but how much it is expressed verbally with the psychiatrist and other specialty peoples, that is unfortunately not very clear. So again, data is missing. Paraphilias include transvestic fetishism, like arousal from cross-dressing. If cross-dressing only during course of gender identity disorders, rules out transvestic fetishism. So there is a very thin line between transvestism and then gender identity disorders, and differentiating both the things, because we are assessing the people on the basis of their presentation and the way they talk to us and how much they are communicating to us. So thin line between the two: transvestic fetishism, transvestism, and gender identity disorders. All of these three things. This is the reason why I'm mentioning these things here. Majority are heterosexuals, feel they have alternating male and female personalities. Tricky. Paraphilias involving non-consenting others like exhibitionism, exposing genitals or strangers for shock effect. Again, not very common, but it is there in literature. Common distressing occurrence for college women. Men show sexual arousal to erotically neutral females. Tend to be young married men. Exposing has a compulsive quality. Now, this is again tricky because it's crossing the boundary of obsession or the impulse control thing. And as in ICD 11, all the impulse control situations are clustered into the obsessive related phenomena. So most of these people, if they are having any obsessional related phenomena, obsessive compulsive related disorders, they are treatable and we can treat them with, of course, psychological, pharmacological, and other management. So again, the importance of assessment is too much significant, and you have to keep that thing in mind. Voyeurism, urges, acts, or fantasies observing unsuspecting person disrobing or engaging in sexual activity. Risk of arrest, prefer victim is a stranger because it is repetitive, arrest is predictable. Frotcherism, recurrent fantasies and behavior of rubbing against non-consenting person, which commonly happens in our society in public transports. It occurs as a part and parcel of traveling into a public transport, unfortunately. So there are people who are doing it, but how many of them comes to a psychiatric facility? I doubt any one of them probably would be presented. Most of them, they end up in jails because of some, again, social issue, and then they are arrested and they are punished for something probably which is there as a disorder, if we consider it as a disorder. Pedophilia. Now, this is a serious offense, and this unfortunately is not taken acceptable by any society. So sexual gratification from fantasies or sexual contact with the children. This is not acceptable in any society. Here in Canada, the punishment for pedophilia or pedophilic tendency is very intense. Most of these men are given actually cyproterone acetate, which makes you a male castration, or you can say physical compound given for castration. And it is continued for years and years till the time they are cleared that they don't have any of those tendencies existing at that time. So I've seen multiple people with these kind of problems, and they've been on male castration medication for a longer period of time. So it's very much objectionable, offensive, and punishable as well. Child sexual abuse is very common in general, and 20 to 30% of women report being victims. So most of the women around the age of 10 to 15, or I should say girls around the age of 10 to 15, they have been reported to being sexually molested, harassed, or touched, or somebody took the gratification out of the contact. It is unfortunate, but this is 20 to 30%, means every fourth female probably is a victim of this kind of an abuse. And pedophile usually is a family member or a friend who is having again direct in contact with the family. In one study, 25% of the victims were under 6, 25% 5 to 10, and 50% 11 to 13 years. Highest recidivism rate among sex offenders. Pedophile profile, they are passive, impulsive, alcoholic, low social skills, possible brain dysfunction, intellectual disability, blah, blah, blah. Now, if you consider these things as a primary psychiatric morbidity, then of course, all the pedophiles out of these 100% are probably will be falling in one way or the other in a psychiatric morbidity situation. So my job is further complicated for the assessment of these people and assessing if they are suffering from any psychiatric morbidity, which most of the time, whatever the data is suggestive, they are. So victims are seriously affected, physical symptoms, nightmares, acting out, sexually focused behaviors, and they lose contact with the reality. So I hope it's not too boring. Just a few more slides and then we'll come to the term which we wanted to talk about. Paraphilia is involving pain or humiliation, sadism, masochism, uh, aggressive sex fantasies, possible, again, in most of the people, there is possible brain damage, especially at the temporal areas. Now, again, as the data is limited, so there's no firm conviction, but it is there. Like you might have heard about the Clover-Bushy syndrome, where there was a bilateral ablation of the temporal lobes. And when you remove both of the temporal lobes, people are hyperoral, hypersexual, say they don't see anything, they eat everything, and they have sex with everything. So the damage to the temporal lobe is actually the key to most of the problems related to paraphilias. And if it is like that, which again, I'm not sure if it is 100% correct or not, as that has limited, then of course it's a brain damage situation and we have to treat that thing rather than paraphilias. Etiology and treatment of paraphilias, again, biological perspective, too little is known. Mostly it's a psychological theories which are probably related to it. Treatment is mostly behavior therapy, sometimes again castrations, chemical castrations. I was just trying to remember the name. It's chemical castration is used for these purposes and strengthening appropriate behaviors, developing social skills, aversive behavior rehearsal, etc., etc. Rape is again sexual aggression and it is mostly accomplished through force or threat or scene of crime of violence. And it is again, whenever the word use aggression, so the sexual aggression leads to rape. So this means the original point is aggression, and aggression is treated in psychiatry as a disorder thing, and we have to treat them similarly. And this was the reason why I'm mentioning it here. Sexual aggression, etiology of rapes, effects of rape. I won't go into that detail, but incest and other treatment strategies utilized for it is they are very much there. So chemical therapy and surgical castrations are the thing. Now the point coming to transgender. So the basic point, my viewpoint, when I was reading through it and I was just assessing what people are saying about in the social media these days because of that bill, I wanted to talk about these things. So as a psychiatrist, I always believe if I'm able to do my job, and I always tell it to my patients as well, try to do your job. Don't involve yourself into other person's job. And if we all in our society are doing what the job is assigned to us, the society will be prosperous. We usually want to become a religious Maulvi, we want to become a politician, we want to become a cricketer, because when the cricket match is going on, people are shouting about it and they feel that they are commenting the way that they are authority in the cricket, but they are actually they know nothing. This is what the problem is most of the time, that we are trying to barge into other people's domain and not taking care of what we should be taking care of. Now, basically, conclusion, whenever these kind of problems are seen, there is employment issue, equality issue, educational issue, health related issue, protection issues, blah, blah, blah. Transgenders usually is again, people who are transgender feel like they are living inside a body That's all wrong for them. They feel trapped in someone else's body. Now, again, if you focus on this dialogue as well, which is very much common in literature, you search through the literature and you will feel this word, trapped in someone else's body. If somebody is trapped in someone else's body, why can't it be a delusion? Why can't it be an obsession? And if it is a delusion, it should be treated like a delusion, like any other delusion. And then why we are hesitant about it? Again, because we are not sure what we are doing. So not all transgender people decide to get surgery or hormones, though. Some are most comfortable by keeping their physical anatomy, but dressing as the opposite gender. So that was very interesting article which I went through. And this psychologist, he postulated a theory. He said that there is only one sex. Again, no evidence for it. It was just a theory. We all are actually male or female because of the XY chromosomes. So double X is a male, and XY is a female. Now, double X means absence of the thing which will make you a female. This means that all of us are actually, this is according to this theory, that all of us are unisexual. We are decided as bisexuals or heterosexuals or any other sex related, female or male gender, because there is one thing missing. So one thing missing and I'm a female. One thing added and I'm female. So this I was surprised about this theory. But again, according to them, there are multiple sexes. There is genetic sex, there is gonadal sex, there is hormonal sex, there is somatic sex, and there is psychological sex, which is psychological sexual identity. And then there is sexual orientation above all. So there is genetic sex, gonadal sex, hormonal sex, somatic sex, psychological sex, and then sexual orientation, which is at the top. Although, again, I was not able to find any specific evidence for it. Then there was another theory about the nature versus nurture, and there were lots of debates about it as well. Learned behaviors and innate behaviors and blah, blah, blah. So now comes the transgender bill in Pakistan. And I will open the forum for discussion. If any one of you have any questions, then we can move forward with it. Anybody?
Sir, I have a question.
Sure, go ahead. Don't worry about the recording. If you are not comfortable because
नहीं
I
नहीं,
am recording it, I can
I have no
stop the
issue.
recording and we can discuss.
नहीं सर, I have no issue.
Go
सर,
ahead.
जैसे अभी हम सारा ये डिस्कस कर रहे थे जेंडर डिस्फोरिया और DSM-5 तक जैसे जेंडर डिस्फोरिया है और ICD-11 में तो मुझे ये कहीं मिला ही नहीं। तो मतलब फिर हम ये क्यों, एज साइकियाट्रिस्ट हमें ये डिस्कस करने की क्या ज़रूरत है? अगर ये कोई डिजीज़ ही नहीं है तो पता नहीं, मतलब आई डोंट नो इफ यू आर गेटिंग माय पॉइंट
ये
और नॉट, क्योंकि
थोड़ा सा
मुझे लगता है
करेक्ट थोड़ा सा करेक्ट करूं।
हाँ, या
एज अ
प्लीज।
साइकियाट्रिस्ट हमें ये डिस्कस करने की जरूरत इसलिए है कि हम ये समझते हैं कि ये सारे लोग, अगेन मेरा व्यू पॉइंट है, यू मे डिसएग्री विद इट, ये सारे लोग जो इस प्रोसेस में इन्वॉल्व हैं, इनमें मैं मिसाल देता हूं। ये भी बड़ी एक इंटरेस्टिंग कहानी जो मैं पढ़ी, मुझे नहीं पता वो कहानी कितनी सच्ची है, लेकिन मैं कहानी कोट करता हूं जो मैंने पढ़ी, कि जो लोग अनफॉर्चुनेटली ट्रांसजेंडर्स, एक्चुअल ट्रांसजेंडर्स हैं, जिनको उर्दू में हम ख्वाजा सरा बोलते हैं और हम एक दूसरा लफ्ज बोलते हैं जो डेरोगेटरी है, लेकिन मैं फिर भी बोल देता हूं, खुसरा बोलते हैं। वो लोग हैं जो एनाटॉमिकली ना मेल होते हैं ना फीमेल होते हैं, ठीक है। ख्वाजा सरा का लफ्ज बड़ा इंटरेस्टिंगली कहानी में आज मैं सुना रहा था एक और डॉक्टर साहब को कि वो जब मैं पढ़ रहा था तो मुझे बड़ी हैरानी हुई, ये लफ्ज ख्वाजा सरा कहां से आया। दिल्ली में ख्वाजगान है जो कि जस्ट लाइक दाता दरबार, दाता साहब, दिल्ली में ख्वाजगान हैं उनके मुख्तलिफ मज़ार हैं, और दिल्ली में मुख्तलिफ वक्तों में ये मुख्तलिफ ख्वाजगान ने एज एज अ सेंट उनके मज़ार हुए या उनकी पैरोकार हुए, और वो उन्होंने इस्लाम को प्रीच किया। वो बच्चे जो एनाटॉमिकली ना मेल्स में थे ना फीमेल्स में थे, उन बच्चों को आमतौर पे वालिदैन इन मज़ारों पे छोड़ जाते थे, और वो बच्चे जब थोड़ा होश संभालते थे, थोड़े बड़े होते थे मज़ारों में वहीं पे खाते पीते रहते हुए, तो उन बच्चों को एफ्लुएंट क्लास, नवाब क्लास अपने घरों में ले जाती थी, और उनका नाम ख्वाजा सरा रखा गया, ख्वाजगान के आसरे से उठाया हुआ बच्चा, ख्वाजा सरा। नाउ दिस इज वेरी सरप्राइजिंग टू मी। मैं बड़ा हैरान हुआ इस पूरी बैकग्राउंड से कि ख्वाजा सरा का ये एक थ्योरी है, मे बी और भी कहानियां हों कि ये लफ्ज कहां से आया। और ख्वाजा सरा इसलिए उनको वो एफ्लुएंट फैमिली ले जाती थी क्योंकि वो दोनों तरफ मूव कर सकते थे। उस जमाने में मर्दान खाना अलहदा और जनान खाना अलहदा होता था। सो जनान खाने को, औरतों को मर्दान खाने में आने की इजाजत नहीं होती थी, और मर्दान खाने वालों को, मर्दों को औरतों के इलाके में जाने की इजाजत नहीं होती थी। सो ख्वाजा सरा, क्योंकि बिकॉज दे वर नॉट हैविंग एनी आइडेंटिटी ऑफ देमसेल्फ, आइदर मेल और फीमेल, दे वर एबल टू मूव अक्रॉस बोथ। वो जनान खाने में भी जाते थे और मर्दाना खाने में भी आते थे, और दोनों की कम्युनिकेशन का जरिया बनते थे। इसलिए उनको ख्वाजा सरा कहा गया, ख्वाजगान के आसरे से आया हुआ बच्चा जिसकी अपनी कोई सेक्स नहीं है। हम उसको आम जबान में यूनैक बोलते हैं। और आपके सवाल का जवाब कि एज अ साइकियाट्रिस्ट मैं क्यों इंटरेस्टेड हूं, इसलिए कि ये 3-4 चीजों में हमें डिफरेंशिएशन करना है। एक वो विक्टिम जो अनफॉर्चुनेटली नेचर की वजह से ना मेल है ना फीमेल है, ठीक है। फिर कुछ लोग एडेड उसमें, जो हमने बात की, मुख्तलिफ ट्रांसवेस्टिज्म है, ट्रांसजेंडर्स हैं, और बाकी सारी जो बातें की, जो डिसऑर्डर्स हैं, फिर कुछ वो लोग ऐड इसमें हो जाते हैं। सो द ट्रू यूनैक ख्वाजा सरा is actually the person who is actually unfortunate victim from every side, from society because he was left at the mazar, from people who were utilizing them as a communicating person between male and female, and then afterwards their number kept on increasing. And even now, if some child is born with no sexual organs, they're not considered to be accepted as a male or a female in the society, and that is a complicated situation. So आपकी बार एज ए साइकियाट्रिस्ट हम क्यों इंटरेस्टेड हैं? हम इंटरेस्टेड उन लोगों में नहीं हैं, बल्कि उन लोगों में भी होना चाहिए जो जो पैदाइशी तौर पे मेल और फीमेल सेक्स ऑर्गन से अगेन फारिग हैं। हम उन लोगों में भी हैं जो ड्रेसिंग करते हैं, हम उन लोगों में भी हैं जो मुख्तलिफ पैराफिलियाज में इन्वॉल्व होते हैं, हम उन लोगों में भी हैं जो जिनको इम्पल्सेस होती हैं और जो एग्रेसिव सेक्सुअल एक्टिविटीज में इन्वॉल्व होते हैं। और एज अ साइकियाट्रिस्ट हम उन सब को असेस और एवेलुएट करके अपनी साइकियाट्रिक इंटरवेंशन स्ट्रेटजीज उस पर अप्लाई कर सकते हैं। लेकिन एज अ साइकियाट्रिस्ट ये जो बिल पास हुआ, मेरे इसको देखने का नजरिया फर्क है। आई होप आप लोगों को समझ आ गई होगी मैं क्या कहना चाह रहा हूं। फर्क इस सेंस में है कि मेरा काम नहीं, ठीक है। मैं क्यों इसमें अपने आप को खामखा इन्वॉल्व करूं इस डिबेट में कि ये बिल ठीक है कि गलत है? जिनका काम है उनको करने दें। हाँ, एज अ पर्सन ऑफ अ सोसाइटी आई मे बी एबल टू रेज माई वॉइस कि ये ठीक है या गलत है। लेकिन इसमें देखें, एक बात नोट करें कि इस बिल को रेज करने की या बनाने की मेन थीम जो मेरे नजदीक, आई डोंट नो अब हकीकत क्या है, जो मेरे नजदीक है वो थीम ये है कि वो बच्चे जो पैदाइशी तौर पे ख्वाजा सरा हैं, यूनिक हैं, खुसरे हैं, जो जेनेटिकली ना मेल हैं ना फीमेल हैं एनाटॉमिकली, उनकी जब आईडी कार्ड नहीं बन सकते, उनकी जायदाद में हिस्से नहीं बन सकते, उनको कॉर्नर कर दिया जाता है, उनको डिसएंगेज कर दिया जाता है, उनको उनको इस सोसाइटी में कोई मकाम नहीं दिया जाता, वो एक्चुअल डिजर्विंग कम्युनिटी है। बाकी सारी चीजें जो उसमें बिल में है मुझे नहीं पता वो सही है कि गलत है, बिकॉज आई एम नॉट द जज। बट व्हाट आई एम सेइंग इज कि अगर वो बाकी सारी चीजें इन्वॉल्व हैं तो फिर उन चीजों को एड्रेस करना चाहिए। डिबेट, आर्ग्यूमेंट्स, लड़ाई will lead us to again nothing. But yes, debate will lead us to one point, which will be either we are doing the justified thing or unjustified thing. But a person who is unfortunately a victim of this natural, a child born with intellectual disability, absence brain, absent temporal lobes, he is having a microcephaly. Do we throw them away? Yes, in our society we do. And same goes with these people as well. Is it justified? Not humanly. I don't believe in that. If they are born and if they are abnormal, it's the responsibility of people, responsibility of society, responsibility of the government to take care of them, because they are living human beings, even with their abnormalities. So मेरे नजदीक अगर आप बात करें स्पेसिफिकली इन लोगों की जो विक्टिम हैं, तो आई विल डेफिनेटली से यस, उनके शनाख्ती कार्ड बनने चाहिए ताकि उनकी सेक्स असाइनमेंट हो, ताकि उनको माँ बाप की जायदाद में से पैसे मिल सकें, ताकि उनको हिस्सा मिल सके, ताकि वो जो उनके बाकी बहन भाई हैं वो उनसे पीछे ना रह जाएं। उनका क्या कसूर है, क्योंकि वो अपनी मर्जी से तो इस तरह नहीं पैदा हुए। Right? Yes, LZ Lareb, you wanted to ask a question. Go ahead.
Sir, I just wanted to ask this. We often see patients who come to us with like they want to dress as other people. Like उनके parents हमारे पास लेकर आते हैं कि भाई हमारी बच्ची है, she feels like she's a guy and she wants to dress as that person. How do we deal with that? Because उनसे बात करें अगर तो they do not report any such problem. They're like this is who I am and I'm very, वो जो cognitive dissonance नहीं होती उनके अंदर कि भाई मुझे नहीं करना या मेरे लिए गलत है या whatever. They're just like why can't my parents accept it? So how, as psychiatrists, when a mother or a father brings such children to us, how do we deal with them? And I'm not talking about trans-sex people. I'm talking about specifically cross-dressers or lesbians or gays. How? Because in a very huge society of the world, it is very acceptable. So, मतलब हमारे parts में नहीं है. How are we supposed to deal with it?
I think, Lareb, you have asked a relevant question because this is what we should be doing, right? This is our job. So what I do, I can coach you myself. I cannot coach you anybody else. What I do is that first I try to elicit. I take the history. I do the mental state examination. I go for a physical examination. I go for other various tests that is needed in that kind of a person. And if I feel that the person is suffering from, say, transvestism, that they prefer to be dressed like a female, and the parents are worried about that, and I have made my assessment, if I would be able to find a psychiatric morbidity at any level, I will treat it with all three parameters. One, biological, giving medications to them, whatever is my diagnosis. Two, psychological, again, counseling to the family and the patients. And three, social, educating people around them what to do about it. So there is a definite set criteria of treatment for all disorders, as I mentioned to you earlier, that I have to assess the person for basic psychiatric morbidity. This is what my job is. And if I'll be able to assess him that this person is suffering from psychiatric morbidity, I will treat it. But if A person comes to me brought by the family, like what you are saying, partially in that sense. If somebody, like I was seeing a male person, and when I was assessing him, he was brought by the sisters that this gentleman is 28 years old and we want him to get married, and he is saying no to the marriage because he is not interested in women. So this was the main reason why he was brought to me. So what I did was that I started talking to the person, I assessed him, and he was definitely suffering from depressive disorder, fulfilling all the criteria of MDD. But on the contrary, he was also saying that he's not interested in the females. He's not actually he never had an encounter with the male as a homosexual act. So he was not a gay per se, but he was not interested in the females as well. So I was thinking that probably he is having asexuality. He's neither interested in women nor interested in men, but the family wants him to get married because he was the brother of 6, 7 sisters, and they want him to get married, to raise children, to bring the family, and then again वही खानदान चलाने वाली बात. तो जनरली मेरा काम तो इतना था कि मुझे उसको असेस करना था. मैंने असेस किया, उसको एमडीडी था, मैंने उसको ट्रीट करने के लिए कहा. उसके बाद वो फॉलो अप पे आया एंड ही वाज फीलिंग मच बेटर. ही वाज वेरी मच ओके. उसके वो जो डिप्रेसिव कॉग्निशंस और एक्सेप्टेंस, वो सारी चीजें ठीक हो गई. लेकिन उसका वो स्टैंड के आई डोंट वांट टू गेट मैरिड बिकॉज आई एम नॉट अट्रैक्टेड टुवर्ड्स द फीमेल्स, वो स्टैंड किया. फिर हमने उनको एज यूजुअल हमने उनको साइकोलॉजिकल असेसमेंट और इंटरवेंशन के लिए भेजा. 6 महीने उन्होंने वो भी कराया और उसके बाद वो डिसअपियर हो गए. ऑब्वियसली आई कैन अंडरस्टैंड, कोई स्किज़ोफ्रेनिया हो तो वो शायद कहीं भी नहीं जाएगा बेचारा. लेकिन एक वर्किंग क्लास का आदमी जो अच्छा खासा कारोबार चला रहा है, जो बिजनेस कर रहा है, उसको डिप्रेसिव सिम्टम्स हैं, तो उसको डिप्रेसिव सिम्टम्स एड्रेस हो गए, उसका कारोबार तो मजीद अच्छा हो गया, वो जिंदगी में लाइवली हो गया, और वो 6 महीने के लिए उसने साइकोलॉजिकल हेल्प भी ली. तो उसके बाद अंडरस्टैंडेबल बात है कि वो कहेगा जी मुझे मजीद अब क्या करना है. बहरहाल ही वाज लॉस्ट. आफ्टर 3 years he came back again to me with a gap of 3 years in between, and he got married and he got a child as well. But again he complained to me that he's not actually interested in his wife or any female. So you see, this is the dilemma. If we are able to see and assess the people per se of what they are, as a psychiatrist, मेरा काम इतना है. उसको रिलीजियस सरमन देना, उसको अगेन स्पिरिचुअल सरमन देना, उसको कल्चर पढ़ाना, ये मेरा काम नहीं है. मुझे सिर्फ उसको एजुकेट करना है about the disorder or disease what he's having, and then I have to tell him the pros and cons and the family and the prognosis and the outcome, and I should do that. That's it. उसको बिल पे लेकर आना और बिल के ऊपर चढ़ाना, I don't know what should I do about it. I usually am not interested in that, so I refrain myself from doing it. Manu, you wanted to ask a question as well. लरेब ये
Yes, sir.
हाथ पीछे कर लो ताकि दोबारा क्वेश्चन पूछना हो तो हाथ खड़ा कर दोबारा. ओके, गो अहेड.
सर मैं जो अपना क्वेश्चन पूछ रही थी, थैंक यू आपने आंसर किया. लेकिन देखिए जैसे अभी आईसीडी में जो मेंटल हेल्थ वाला जो चैप्टर है उसमें उन्होंने ये जेंडर रिलेटेड कोई किसी इशू को नहीं डाला. जैसे DSM-5 में जेंडर डिस्फोरिया था, ठीक है, उन्होंने इसको अलग से एक चैप्टर 17 है जो मैंने देखा है, मतलब जो मुझे पता है अभी तक, आप मुझे करेक्ट कर सकते हैं प्लीज, डिसऑर्डर्स रिलेटेड टू सेक्सुअल हेल्थ, ये मुझे उसमें मिला था. ठीक है,
बिल्कुल.
वहां पे इन्होंने इसको डाला है जेंडर इनकॉन्ग्रुएंस के नाम से. ठीक है, अब देखिए हम ऐसी सोसाइटी में रहते हैं जहाँ पे ये चीजें बहुत ज्यादा एक्सेप्टेबल नहीं, बहुत ज्यादा क्या बिल्कुल ही एक्सेप्टेबल नहीं
किसी
है.
भी सोसाइटी में एक्सेप्टेबल नहीं है.
अच्छा
आपने कहा कि किसी भी सोसाइटी में एक्सेप्टेबल नहीं.
सर मेरा क्वेश्चन सुने ना प्लीज पहले पूरा. अच्छा, तो मतलब यहाँ पे आप जैसे कनाडा में रहते हैं तो आप बेटर बता सकते हैं कि वहाँ पे कितना स्टिग्मा एसोसिएटेड होगा जेंडर डिस्फोरिया के इश्यूज को लेके, या यहाँ पे कितना, आई थिंक यहाँ ज़्यादा ही होगा, या इस पे आप भी बताएं जैसे भी है। लेकिन अगर उन्होंने इसको अलग उसमें डाला है तो एज अ साइकियाट्रिस्ट, अब अगर कोई पेशेंट हमारे पास आता है, मतलब एज अ रेजिडेंट मेरे जहन में एक क्वेश्चन है, कोई पेशेंट हमारे पास आते हैं, हम उसे असेस करते हैं, फॉर एग्जांपल अ फीमेल कम्स और वो कहती हैं कि मैं मतलब अपने जेंडर से सेटिस्फाइड नहीं हूँ और मुझे लगता है दैट आई एम अ मेल और ये सारी चीज़ ठीक है। तो लेकिन मैं उनको डिलूजन्स के लिए भी असेस कर सकती हूँ, मैं उनको ऑब्सेशंस के लिए भी असेस कर सकती हूँ, मैं उनकी हर चीज़ देख लेती हूँ और उसमें ऐसा कुछ भी नहीं है। तो बस फिर तो शी इज़ नॉट माई पेशेंट। आगे वो जो 2-3 साल वाली चीज़ जैसे आपने बताई कि जो पहले हुई और सबकी, लेकिन अब तो वो फिर हमारी डोमेन में है ही नहीं। पता नहीं, दिस इज कंफ्यूजिंग मी सो मच, मुझे नहीं पता,
This is
शायद मैं
not
आपको
at
भी
all
कंफ्यूज कर रही
confusing.
हूँ।
This is not at all confusing. You are
तो फिर व्हाट शुड बी
absolutely,
आवर अप्रोच नाउ?
this
अब
is,
इसको
you are absolutely right. This is the approach. What I'm asking you to do as a professional, as a psychiatrist, this is what you are supposed to do. आपके पास पेशेंट आया है, आपने उसको असेस किया है, आपको साइकियाट्रिक मॉबिलिटी मिली है, आपने उसको ट्रीट किया है, साइकियाट्रिक मॉबिलिटी नहीं मिली और आपको लग रहा है कि ये वो इशू ही नहीं है, बस ठीक है, दैट्स इट, ही इज नॉट योर पेशेंट. Why I have to treat everybody who is coming to my clinic? Why? Why do I have to treat everyone who is coming to me? I don't have to. This is unfortunately another problem. कि डॉक्टर के पास गए हैं तो कुछ तो होगा, कुछ नहीं हो, जरूरी नहीं है कि कुछ होना चाहिए. अगर डॉक्टर के पास गए, डॉक्टर ने असेस किया और उस पेशेंट को दवाई की जरूरत नहीं है या किसी और इंटरवेंशन की जरूरत नहीं है तो मत करें. जरूरी है कि आपने लाजमी उसको ट्रीट करना है जबकि उसको साइकियाट्रिक मॉबिलिटी है ही नहीं.
उसको साइकियाट्रिक मॉर्बिडिटी नहीं है, उसे बस ये मसला है कि मेरा जेंडर ठीक नहीं है एंड ही वांट्स टू गेट इट चेंज।
देखें, बात फिर वही, मैंने आपको वो पैरामीटर सारे दे दिए कि अगर आपने देखा कि साइकियाट्रिक मॉबिलिटी नहीं है और इसको प्योर जेंडर आइडेंटिटी डिसऑर्डर है तो उसका जो ट्रीटमेंट स्ट्रैटेजी बयान की गई है वो मैंने पहले आपको
नहीं
समझा
नहीं
दी.
सर, वो नहीं वो आपने बिल्कुल सही समझाई, लेकिन अब तो वो लेटेस्ट क्लासिफिकेशन सिस्टम में तो हमारी डोमेन ही नहीं है, तो व्हाई शुड वी डू दैट
अभी
इवन?
तक उस ट्रीटमेंट स्ट्रैटेजी में जो मैंने आपको बताई है उसमें कोई चेंज नहीं आया. वो ट्रीटमेंट स्ट्रैटेजी वैसी ही है कि अगर कोई शख्स है वो आपके पास है, साइकियाट्रिस्ट आता है, आप उसको असेस करते हैं, उसको कोई साइकियाट्रिक मॉबिलिटी नहीं है, उसको सिर्फ आइडेंटिटी डिसऑर्डर है या सेक्सुअल इनकॉन्ग्रुएंट डिसऑर्डर है, तो वो फिर मेरा पेशेंट नहीं है. मैं उसको
या
देखूंगा, असेस करूंगा, साइकोलॉजिस्ट के पास सेशंस के लिए भेजूंगा, फिर मैं एंडोक्राइनोलॉजिस्ट के पास रेफर करूंगा और फिर मैं सर्जन के पास रेफर करूंगा.
ओके ठीक है,
बात खत्म.
ओके।
इसमें
एंड
कंफ्यूजन किस बात की है? कोई कंफ्यूजन
पता
नहीं.
नहीं, मुझे बहुत कंफ्यूजन है सर।
नहीं, कोई कंफ्यूजन नहीं है. यू हैव टू स्टिक टू इट. जो हमें बताया जाता है किताबों में, लिटरेचर में, डेटाबेस में, आईसीडी 11 में, डीएसएम 5 में, हमें वही करना है. हमें उसको रिलीजन से, हमें उसको क्रिश्चियनिटी से, इस्लाम से, किसी भी रिलीजन से नहीं मिलाना और मिलाना चाहने की जरूरत ही नहीं है. मेरा काम नहीं है. अगर उसको कोई रिलीजियस सरमन लेना है, किसी रिलीजियस स्कॉलर के पास जाए. अगर उसको कोई और इस तरह की जरूरत है तो वो लीगल इश्यूज में जाए. मेरा क्या काम है?
सर
लेकिन
हाँ।
हाँ, लेकिन वो बात कि मैंने आपको क्लियर कर दिया कि ख्वाजा सरा, they deserve our sympathies. They deserve to be included in things. Reason? Because ये उनका कसूर नहीं है कि वो पैदाइशी ना मर्द हैं ना औरत. So as a human, मुझे डेफिनेटली मैं उनके साथ हूं, लेकिन एज अ साइकियाट्रिस्ट मेरा व्यू पॉइंट यही है जो मैंने आपको कन्वे किया कि एज अ साइकियाट्रिस्ट आई हैव टू डील विद द थिंग्स प्रोफेशनली. I know that some of you are not happy with it, but anybody, any other thing.
अच्छा सर, I have one more question.
Sure, go ahead.
सर, अब प्यूबर्टल ब्लॉकर्स की बात हो रही थी तो मैं उसको देख रही थी. प्यूबर्टल ब्लॉकर जैसे प्यूबर्टी पे देते हैं, जैसे द पर्सन्स हु आर नॉट हैप्पी विद देयर जेंडर इन, तो प्यूबर्टी के आसपास आप उन्हें प्यूबर्टल ब्लॉकर्स देंगे जिससे जो भी उनके जो नेचुरल सेक्सुअल कैरेक्टरिस्टिक्स हैं वो सप्रेस हो जाएंगे. तो आप मुझे बताएं कि एज अ माइनर, मतलब प्यूबर्टी में यू आर अ माइनर, आप उसमें वो देने के लिए प्यूबर्टल ब्लॉकर्स दे. एक तो ये कि वहाँ मैंने पाकिस्तान में तो मैंने कभी देखा नहीं, ना मुझे आइडिया है कि देते हैं या नहीं देते. लेकिन एज अ माइनर आप क्या खुद ये डिसीजन ले सकते हैं कि आपने प्यूबर्टल ब्लॉकर आपने लेना है या नहीं? ये तो पेरेंट्स पे नहीं होगा डिसीजन. ये
Definitely,
क्या
definitely. अगर तो अंडर द एज ऑफ 17 है तो ये डिसीजन पेरेंट्स का है. Above the age of 17, they have the liberty to go for themselves. Consent एडल्टहुड में आती है और एडल्टहुड की एज हर मुल्क की अपनी डिफाइंड है. कनाडा में एडल्ट 18 पर हैं, यूएस में 16 पर हैं, as far as my knowledge is concerned. पाकिस्तान में भी 18 साल की उम्र है, लेकिन पाकिस्तान में वेरी करती है. लड़कियों में 16 है और मर्दों में 18.
सर, कनाडा में प्यूबर्टल ब्लॉकर्स का जो यूज होता है वो होता है, आपने देखा है? और वो मतलब कैसे होता है, क्या होता है?
नहीं, मैंने नहीं देखा, लेकिन अगेन अगर आप हार्मोन्स की बात करें तो इस मुल्क में हर लड़की जो प्यूबर्टी में आती है उसको हार्मोन्स दिए जाते हैं, बर्थ कंट्रोल्स दी जाती हैं. मेजॉरिटी, ना हर तो नहीं कह सकता मैं, मेजॉरिटी को दी जाती हैं. क्योंकि अगेन ओपन मुल्क है, रिलेशनशिप्स इस उम्र में बहुत ऑफ एंड ऑन ख़राब हो जाते हैं, जो यहाँ पे खैर इस अगेन सोसाइटी का नॉर्म है. सेक्सुअल रिलेशनशिप्स 15, 16, 17, 18 साल की उम्र में. So just to make sure that they don't conceive and give rights to birth, because abortion illegal है, तो birth control pills दी जाती हैं. लेकिन उसका उस तरह से मैंने नहीं देखा अभी तक, मेरा एक्सपीरियंस नहीं है. सो आई वोंट बी एबल टू से एनीथिंग कि वो सप्रेस करने के लिए दवाई दी जाती हो. हाँ, मेरा एक्सपीरियंस ये है कि पीडोफाइल्स को, जो पीडोफाइल्स हैं पेशेंट्स, उनको साइप्रोटिरोन एसीटेट दी जाती है और वो अब जेल फॉर्म में आती है. तो डेली उनको एक खास अमाउंट की जेल अपनी स्किन पे इस्तेमाल करनी है ताकि वो मेल chemical castration persist करे. They are forced to use these medications who have the pedophilic tendencies, males. Got the answer?
Yes sir, thank you so much.
You're welcome. Chale, let's hope that you people have more vision about it. And I know that there'll be some disagreements. I'm not saying that there won't be any because it's a very sensitive topic. लेकिन मैं expect कर रहा था कि बहुत सारे लोग बोलेंगे, जैसे जुबैर बोलेंगे, तमीना बोलेंगे, लेकिन बोले नहीं. So कोई बात नहीं, अगली दफा फिर हम दोबारा फेस टू फेस कभी मिलेंगे तो इस चीज पे एक बैठक डायरेक्ट लगा लेंगे ताकि आप लोग खुल के बात कर सकें. राइट? क्वेश्चंस पूछा करो एज साइकियाट्रिस्ट, जरूरी होता है, अच्छा होता है. ओके, थैंक यू वेरी मच फॉर ज्वाइनिंग एवरीवन. See you again. Allah Hafiz.
Thank you, sir. Allah Hafiz.
Allah Hafiz sir.